Welcome to Care Transitions Today, Case Conversations, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we dive deep into the world of healthcare case management and transitions of care. Today, we are joined by three physicians, Dr. Rebecca Severe, Dr. Sweta Singh, and Dr. Teresa Jacobs. Dr. Rebecca Severe is a hospital medicine certified physician serving as Medical Director of Care Management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Dr. Teresa Jacobs is a clinical professor of neurology at the University of Michigan and is a distinguished expert in neurocritical care. Her wealth of experience in teaching and research brings invaluable insights to our discussions surrounding a variety of intricate case scenarios. In this series, we'll explore the challenges and triumphs of real-life case studies, providing valuable insights for healthcare professionals and anyone interested in the intricacies of patient care. Whether you're a seasoned physician advisor, a dedicated case manager, or simply someone passionate about improving healthcare outcomes, Case Conversations is your go-to resource for compelling stories and expert insights. This is Care Transitions Today, Case Conversations.
Hi, Rebecca. Hi, Teresa. Good to see you guys again. So I have this pediatric case that I wanted to share with you guys today. It's a 14-year-old with a history of dilated cardiomyopathy with MYH7 and status post recent orthotopic heart transplant. And the transplant happened exactly a month before this admission. And so was taken to the cath lab on the morning of day one for routine diagnostic right heart cath and biopsy to evaluate for presence of allograft rejection in the setting of heart transplantation. Post-procedure, the patient had echocardiogram performed, and it was concerning for some pericardial effusion. The pediatric cardiology service had concern about this post-biopsy. And to give you a clear what the biopsy it says post-biopsy echocardiogram showed small to moderate pericardial effusion. The effusion located posterior to the LV around the right atrium are unchanged from the prior study performed earlier in the day. So they admitted for echocardiogram close monitoring, put on the tele, and had the patient be on Q4-hour vitals. So this second echocardiogram is later in the day to see how things are moving, and since it still shows, the plan was made to keep the patient overnight for monitoring and repeat echocardiogram next morning. I want to pause here and pick your guys' brain on what do you think in terms of patient class, in terms of observation versus inpatient. Just one more thing I want to bring up in terms of level of monitoring. As you know, we have general medicine floors, we have ICU level. This patient was put in intermediate level due to the care need.
Were there any laboratory studies done, Sweta, at admission that might have swayed us more to think that there was inpatient medical necessity aside from simply monitoring and repeating echo?
There were basic lab done on admission, but no in terms of any changes in the labs that were concerning.
Okay, so no white count, no fever, no other compelling reason for being in a hospital setting?
Not that I can remember. But a little bit after the biopsy, again, if there was white blood cell count rise, I won't be surprised, but at the same time, there were no IV antibiotics started. There was the Lasix given on admission, and also diuretics were managed in terms of future doses, and it was changed from the home dose to try help with this pericardial effusion.
It's feeling like observation to me so far, just with it being more of, a planned procedure, likely didn't have an inpatient auth for that. I'm guessing, maybe I'm wrong on that, but likely an outpatient auth. We're kind of monitoring a dose of Lasix. I don't know that most of the payers I deal with would feel compelled to give me inpatient with what we have so far. Now, I guess the question is, what is the etiology of that, effusion, and is something more aggressive need to be done? So that's where my head is right now.
And I would agree with Rebecca completely. However, I would make the argument that there is potential risk here, especially if you have a pericardial effusion. If that were to worsen and the patient were, say, outside the hospital, that could be fatal. If that were an expansive pericardial effusion, that would then cause a tamponade physiology and the patient could die. So if you want to look at severity and risk, that you could make that argument, but I agree if the patient's hemodynamically stable and you're simply monitoring, I'd be inclined to call it observation, but be very quick to create the inpatient designation if anything else shows up.
So I think then this case was reviewed a night later, so next morning, where a repeat echo, now this is the third echo that's being done, and again is showing moderate pericardial effusion and is concerning from that perspective, so they're adjusting. The reason it was brought up to our attention is initially it was determined observation, but like Teresa, you pointed out, there is enough medical necessity, severity of illness, and intensity of services because patient did require, it's not just a post-procedural bleed that needs monitoring in terms of still we can get away with Q8 vitals. It's a pericardial effusion where they're doing telemetry monitoring in Q4 vitals, adjusting the diuretics, and interqual was met actually for this patient. So patient did end up discharging later in the day on day 2. So overall length of stay was not beyond 48 hours like we would like for these patients to before we start jumping into inpatient. But this definitely did have some components that I wanted to bring up and discuss and ask. And so had 2 other PAs reviewed to try find the consensus. And because one interqual met, so our pair for this particular patient, we have an agreement, like if interqual met, we will argue or go for inpatient. And in terms of getting a prior authorization, we were not expecting this to be a complicated procedure, right? Routinely, a 30-day post-transplant right heart cath biopsy patients do end up leaving the same day. And this is a pediatric, or in general, what we also worry about, like in terms of recovery. So another reason that adds the complexity and just 30-day out from heart transplant. So given all these things, we did go for inpatient. Before I go any further, does that make sense? Any questions on that?
And I guess I would have to go back and look at interqual around this. Does the transplant elevate this particular patient to inpatient? Okay. Because otherwise, I didn't hear anything else about this effusion that necessarily, for me, made it, inpatient. There wasn't, some vital sign instability. I didn't hear we had it. It was enlarging or symptoms or concern for infection. But it's that transplant that actually brings them into inpatient criteria, which can't say that I've looked at a lot of transplant, for pericardial effusion and inpatient criteria. So that's a good point.
So, sorry, did the payer say, we're not paying inpatient?
This is a relatively new case, and we haven't heard back differently. But I think if the payer does deny, I still would like to because my next question comes is when I'm determining these cases, say if the payer denies, do I want to go ahead and appeal or go for peer-to-peer? I would say in this case, because of that, like you said, the heart transplant elevating their risk and helping us with that interqual, which a lot of times, let's be honest, is already pretty stringent in terms of what they are calling as observation and inpatient. And we had an inpatient order on this patient. So I think we would still go ahead and like an opportunity to discuss as a peer-to-peer rather than doing a self-denial and calling it as an observation. But we still have to hear it's a relatively new, but I thought it was very interesting because of the length of stay that always makes it hard. Is the inpatient or observation only determined by length of stay, or if we go by the basic concept of the components that we like to see something to be inpatient, medical necessity, severity of illness, and intensity of services, if those three are met, then we want to go towards inpatient or still take a step back if the length of stay is short.
No, and I think it's always helpful, like you mentioned, to know what your payers, if they are going to approve. If they are really strict about their criteria, you need to hold them to that, because it can't be a situation where it was a longer stay, but a lot was going on, but it didn't meet the really narrow criteria, and they won't give you inpatient. But if it meets it and your stay is a little shorter, you don't get it. So I'm all for, if it is meeting, if it meets the criteria your payer follows and they say they adhere to it, I would be inclined to push it then. So I don't know, Teresa, would you do it differently?
Yeah, no, I agree. I think that the case should be argued with the payer because of the risk here and the potential for badness to happen to this child, this 14-year-old. And if they've said and they've committed in contracting to call something an inpatient if it meets interqual criteria, then they should call it inpatient. And so I think the discussion needs to be had. I think you can make it on the basis of contracting if there's an agreed upon contract stipulation, but I think you can also still make this case based on the risk profile for this 14-year-old with a heart transplant and a pericardial effusion. I think that you could still make that medical necessity argument. And then they might say to you, well, you let them go in just a day. Are you no longer concerned, or what's the story with that? Which, fine, we can discuss it, but that's why we do peer-to-peer with a doctor to a doctor, so that we can discuss those issues.
I will be honest, I've seen that not uncommonly in the pediatric population. For example, febrile neutropenia. On the adult side, barely ever they get discharged in less than 48 hours, but it's not uncommon in pediatric side because they have plan in place for close follow-up, and they know the kids' parents would bring them back, or they have that standing relationship. So this patient was discharged with plan for coming back in for echo and repeat clinic visit in just 2 days. So I think that's where they have that safety net, and keeping in mind like these, especially a lot of times with some of these major transplants, they have them patients stay in the close vicinity where they can easily be brought in for sometimes to like 100, 150 days, and depending on the transplant. So they keep all those safety measures in place. So that's why, even though if those things were not in place, yeah, there be a need for closer monitoring persistently. And because they have those options or those safety measures in place, the length of stay is able to be shorter on these patients.
Great. Thanks for that case, Sweta.
The Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. APPLCOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. AppleCom is inclusive of all practice settings. Membership in AppleCom also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, AppleCom membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers, join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acmaweb.org/membership to learn more. Let's continue with our next case.
You guys want to hear another short stay kind of case?
Sure.
Absolutely.
Okay. So what I have for you is a 32-year-old male. He has a history of anxiety, depression, prediabetes. He came into our ED with a dental problem. He really goes back a little bit because he'd been to the dentist and he had tooth number 31 removed. 48 hours after leaving the dental office, he began to develop fever and swelling. And he called the oral surgeon's office and they prescribed him Augmentin. The outpatient therapy failed and his symptoms got worse with the fever and the swelling. And then he went to an outside hospital close to his home. And when he was at the hospital, they did a CT scan there, and the CT scan showed that number 32, the adjacent tooth, had become impacted, and there was a suspected abscess in the right submandibular, sublingual, and the masticator space. They transferred him to our emergency department for a higher level of care. So he came in, he was hypertensive, tachycardic with a heart rate over 110. His exam revealed a right mandibular tenderness, trismus with less than 2 millimeters ability between the incisors for expansion. His laboratory studies showed a prominent leukocytosis. We placed an IV, started IV fluids, gave him IV antibiotics, gave him pain medication, and called dentistry to come see him. Dentistry came to see him. However, because of its location and the lingual abscess, they felt it was outside their scope of care and asked us to call our oral maxillofacial surgeons, which we did. They planned the patient to go to the OR emergently to perform I&D of the fluid collection with possible removal of tooth number 32. And the admitting physician from the ED said that he had an expectation of greater than 2 midnights for this patient, which, by the way, in the ED, a difficult airway evaluation document was prepared and placed into the patient's chart. And given the patient's swelling in the region of his mandible, intubation would not be able to occur through a typical procedure, and he would have to have a nasal intubation, and that was documented in this difficult airway note. So let me stop right there and ask you, what would you guys do on admission? Would you call him inpatient or observation? That was our question initially.
These, for me, these head and neck cases, with various abscesses are tricky. I hear the difficult intubation. I don't hear airway compromise from what you've described so far.
Mm-mm.
So, that always makes it a little bit harder. I hear some tachycardia, so that maybe makes me think he's a little bit more systemically ill from this, but not quite sure if it tips over to inpatient. I don't know. I'm on the fence with this one here. I'd probably look hard at my payer, maybe see if I could understand, how bad the, ENT maxillofacial surgeon thinks this is. Sometimes they think they're going to need to do a couple procedures, and that can help me sway, towards inpatient. Sometimes I'm surprised at how quickly these guys get out, and then I find that those don't get approved. So I don't know, kind of on the edge, wanting to make it inpatient, but not 100%.
Would it affect your thinking, Rebecca, if you knew that the OMFS guys said, we need to go to the operating room now with only 2 millimeters space?
Yeah. I mean, it sounds like this is more serious, and it's just, sometimes if I'm not sure, that's where kind of reaching out to the attending and say, clarifying how bad this is, if it's more on the scope of the dental abscess and maybe could have been dealt with an outpatient. to how much is this, urgent, emergent, any airway compromise, that kind of thing, then that would push me in that direction. And what kind of payer are we dealing with? You mentioned 2 midnight expectation. Is it Medicare or?
This is a commercial payer.
Commercial.
So being a hospitalist by background, I do get to take care of a lot of dental abscess patients in our short stay unit. Generally, they come with facial swelling, and then they get dentistry to do IND at the bedside, and then discuss the tooth extraction plan, 24 hours of IV antibiotics, see if things settle down, can switch to oral and discharge. This case is different from what I would expect in a observation dental abscess patient. It's one patient showing signs and symptoms of systemic infection. So I won't be surprised if there is bacterial translocation happening with that fever, right? It's not just facial swelling, it's like systemic symptoms, fever, tachycardia, and to dentistry. Already made an attempt, patient was on oral antibiotics, failed the oral antibiotics, and they had to have OMFS come in and take the patient to the OR, not just like, hey, let's plan on doing this tomorrow or XYZ time, fixed timing, rather more emergently. So those are the things that make me sway more towards the inpatient. And like Rebecca, you said, a lot of times they get hard to discuss in terms of, I've done peer-to-peer where commercial provider or payer have come back saying, it's a dental abscess. These are almost always observation, and be like, yeah, but this is not your usual bread and butter dental abscess patient that we see in our short stay unit. These are the things that are variant from those usual patients. And their length of stay can definitely be hard sometimes to say because they do recover once we take care of the source. But that doesn't mean there wasn't enough intensity of services or severity of illness. So going by that, I would be in favor, and especially if there is an expectation of more than 2 midnights and that more than 48 hours of stay and need for IV antibiotics because they failed the oral, and also to capture all that, especially around the procedure when they are draining, there will be still translocation happening. I think I would try starting with inpatient.
Yeah, that's what we did. We called it inpatient. So here's some more of the story. The patient got taken to the operating room. Anesthesia evaluated the patient. In their note, they noted that the patient had some missing teeth, broken teeth, and several other mouth infrastructure problems. They had a very difficult time with this patient in the nasal tracheal intubation that had to occur. So it was not a simple intubation getting ready for a procedure. The surgeon did an IND, a tooth extraction, and placement of a drain. All the consents were done, etc. And they found in the operating room, quote, purulence expressed from the right mandibular neck incision, and then tooth 32 was extracted surgically and a Penrose drain was placed. The patient then was admitted for further monitoring and management after postoperatively and received IV Decadron on both the initial day of the surgery and the following day at a dose of 8 milligrams. The drain was monitored for its volume and quality of output, and the patient had pain treated with IV Dilaudid 2 doses, IV Ketorolac 1 dose, IV Fentanyl 3 doses, after which on the third day or late the second day, the patient was switched to PO, oxycodone, and ibuprofen. The patient was started on IV fluids of note originally back in the emergency department because of the tachycardia, and he continued on those fluids for the 3 days, so over 2 midnights. And then also it's noted in the nursing notes that on that second night, the time was 23:26 on the nurse's note, that the patient again became tachycardic compared to his baseline and had an elevated blood pressure and was provided with extra pain medication. So he got IV antibiotics, broad spectrum, prior to the emergency room, and then he continued to receive antibiotics through his third day of care, clear until the time he was discharged at 5:30 in the afternoon. And then the nurses did education regarding care of the surgical wound, medications, follow-up appointments, etc. So he was discharged at 7 p.m. on his third hospital day. And his final cultures, by the way, grew Peptostreptococcus, Canella corridens, and Paramonas micra. So he had 3 different organisms of various types that were growing out of his culture. That was found after the day that he was discharged, but he was continued on PO antibiotics in the outpatient setting. So this case was reviewed by the payer, and the payer says, no, this is not justified to be an inpatient, even with all that extra information, etc. So how do you feel about that? Do you feel that that's a justifiable denial by the in-payer? Rebecca, what do you think?
I mean, I think how it ended up playing out to me feels like inpatient. You had some duration, you had some persistence of your symptoms. You had yes, this was a really hard intubation. And I guess it sounds like those details were in the chart. Like you had enough there. So I feel like it's one I would go after. Now, you never know what your payer is going to agree with, but I think it did shape up into a solid inpatient.
I agree. I think now that we have more information and patient definitely stayed or required services more than the 48 hours and had that need for persistent symptoms and monitoring, especially drain in place. That's not very common. Even if peer denies something, I would like to go after and appeal and the decision and continue on that path and support the inpatient through.
Okay. Well, that was my short stay case for you guys for today.
Thanks for bringing that. That's a very interesting case and good case, especially because we do see commonly dental abscesses, but then keeping in mind things that are common may have variations that we have to try capture.
Yes, I definitely feel that this patient was on the more difficult spectrum as far as dental abscesses are concerned.
And hopefully you guys get this one overturned. I think it's worth it.
Thanks, you guys.
Thanks.
Thank you to everyone for joining us for another episode of Case Conversations. We would also like to thank Drs. Sabir, Singh, and Jacobs for sharing these interesting cases in these episodes. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so you're notified when we upload new episodes. Until next time, this was Care Transitions Today, Case Conversations.